This is a 61-year-old guy with a 80cc prostate. He's been in urinary retention for 6 months now. We've tried multiple medications, and he's seen a number of different urologists that have offered different options. He really is prioritizing sexual function and wants to have a procedure to minimize the risk of retrograde ejaculation. Here we go. This patient presents with an 80-gram prostate. Prior to placing the transrectal ultrasound probe, I always review the patient's medical history for any relevant rectal pathology, such as hemorrhoids or a history of pelvic radiation therapy. I also perform a digital rectal exam to assess rectal tone and anatomy before proceeding. To aid in comfort and probe placement, I instill 60 cc's of surgical lubricant into the rectum and apply additional lubricant to the tip of the truss probe prior to insertion. I begin by inserting the truss probe in the sagittal view, ensuring it remains parallel to the floor during advancement. I advance the probe into the rectum until I can clearly visualize 2 to 3 centimeters of bladder space. If resistance is encountered, I stop immediately, remove the probe, and reinsert it with a more posterior trajectory. I apply adequate anterior compression to optimize visualization of the prostate and bladder. Next, I switch to the transverse view to confirm that the prostate is centered in the image, from the bladder base to the mid-prostate. I make fine adjustments as needed, always keeping the truss probe aligned with the patient's midline to avoid off-axis views. I now switch back to the sagittal view and re-advance the stepper, returning the truss probe to its original position to again visualize 2 to 3 centimeters of bladder space. Finally, to allow for smooth handpiece insertion, I create a slight downward angle by lowering the back end of the stepper cradle. This sets the stage for accurate handpiece placement. This is a good opportunity to highlight the advantages of image-guided technology. In this view, we can clearly identify all critical anatomical landmarks, including the bladder space, bladder wall, intravesical median lobe, bladder neck, seminal vesicles, prostatic adenoma, and the apical region. This level of detail enables precise treatment planning, helping ensure both safety and effectiveness of the procedure. An additional feature of the HYDROS system is its ability to perform prostate volumetric measurements. In the transverse view, I obtain the height and the width, and in the sagittal view, I measure the length. The HYDROS system then automatically calculates the prostate volume. For this patient, the calculated volume is 79.5 grams, which closely aligns with the MRI-based measurement of 80 grams. I will now insert the Aquablation handpiece, which is 24 French and consists of 3 distinct components: the aspiration tube, water jet, and a digital scope. Before insertion, I ensure that the scope tip is fully advanced to allow for atraumatic entry. I then gently introduce the handpiece into the patient's penile urethra, maintaining alignment and minimizing resistance. You can see it's a little tight here at the membranous urethra, but just a little gentle pressure will be able to advance it through. You can also visualize the Vera Montana, which I will identify and reference when planning the Vera protection zone in a later step. So he had large obstructing lateral lobes, a median lobe, and very poor bladder health. You can see these trabeculations and small bladder stones. I now advance the handpiece so it's positioned 1 to 2 centimeters beyond the most proximal prostatic tissue, in this case the patient's intravesical median lobe. Once the handpiece is mounted to the articulating arm, I raise the handpiece into the anterior position. The handpiece position is the ground truth and should be located in the anterior commissure at the 12 o'clock position, which can be confirmed with the scope. The instrument alignment goal is that the handpiece and truss probe are collinear and coplanar. If alignment adjustments need to be made at this point, it should be done by the truss probe. Next, I retract the scope tip to perform cystoscopic visualization of the external sphincter, and finally position the scope tip just in front of the external sphincter, which will define my treatment endpoint. We will now perform jet alignment, which takes place in 2 ultrasound planes. We begin in the sagittal plane, where the goal is to align the water jet plume with the vertical blue line on the screen. I do this by adjusting the truss probe using the knobs on the stepper. Next, I switch to the transverse plane. Here, the objective is to position the hyperechoic shadow of the handpiece at 12 o'clock and the water jet plume at 6 o'clock. I achieve this by rotating the truss probe using the stepper cradle And if needed, I fine-tune the alignment using the rotational adjustments on the handpiece. The next step of the procedure is angle planning. In the transverse view, I retract the truss probe to visualize a cross-section of the prostate. The patient has an intravesical median lobe, so I begin by enabling the median lobe tab. I place marker number 1 on the horizontal hypoechoic lines at the handpiece, which represent the water jet and aspiration tube. I then adjust marker number 2 to define the desired treatment depth, and markers 3 and 4 to capture the lateral treatment zones. Next, I scroll back to identify the widest cross-section of the prostate in the transverse view. Using First Assist AI and image recognition software, the system automatically identifies the capsular borders to support accurate and efficient planning. In this patient, based on the current cystoscopic view, I observe obstructive lateral lobes. To better address these, I adjust marker number 2, number 3, and number 4 to encompass the enlarged lateral lobes and ensure a comprehensive and personalized treatment plan. And then I'm going to fine-tune things based on what I see. And I'm going to move 4 up a little bit. I want to keep it in the capsule. This will best address those large lateral lobes. I think that looks great. The next step is nozzle registration, which takes place in the sagittal ultrasound view. I advance the truss to visualize the bladder space and the tip of the handpiece. Once the tip is clearly identified, I step on the foot pedal to engage the water jet, which helps in locating the nozzle. After confirming its position, I mark it. This is indicated by an N on the ultrasound display. A secondary marker, P, will also appear once registration is complete. Next, I'll move to profile planning, which involves identifying and marking 4 key anatomical landmarks. Treatment start, typically near the bladder neck, mid-prostate, and treatment end, usually near the apex of the prostate. These markers define the length and location of the treatment zone. You can either place them manually based on your interpretation of the ultrasound image, or use First Assist AI to assist with automatic identification. Once these markers are accurately positioned, I transition to contour planning. This step is critical as it allows you to map the exact treatment boundaries and cross-section, tailoring the therapy to each patient's unique anatomy. You should assess the thickness and symmetry of the prostate, look for variations in lobe size or asymmetry, and make adjustments to the contour lines as needed. You'll notice purple horizontal markers displayed at the median lobe and mid-prostate. These reflect the depths defined during the angle planning stage. During contour planning, you can also adjust the bladder neck zone and verumontana protection to ensure that the plans avoid critical structures and deliver a personalized, safe, and effective treatment. I would also note that the varu protection zone can be adjusted based on the patient's needs. For patients who are sexually active, preserving this zone may help maintain ejaculatory function. Conversely, if complete tissue removal in the apical region is required, the protection zone can be minimized or removed accordingly. We are now ready to proceed with treatment based on the finalized plan. Before starting, it is important to confirm with anesthesia that the patient is fully sedated and are paralyzed to ensure there is no movement during treatment. I initiate treatment by stepping on the foot pedal to activate the water jet. In this video, the footage is at 4x speed, but in real time, you'll be able to visualize the tissue respond clearly on ultrasound. Treatment begins at the most proximal region of the prostate, which in this case is the median lobe. Throughout the procedure, the 3D model of the HYDROS system provides a helpful overview of the treatment plan, including resection zone, angles, depth, and power setting for key areas like the median lobe, bladder neck, mid-prostate, and verumontanum zone. During treatment, I ensure the water jet tracks precisely along the horizontal blue line, which confirms accurate nozzle registration. At any time, I maintain complete control of the water jet and can easily adjust power settings. For example, reducing power with a single press of the minus button on the motor pack to tailor treatment in real time based on intraoperative feedback. This is the butterfly cut, a lateral ablation near the apex that spares the midline urethral floor to protect ejaculatory ducts and help prevent retrograde ejaculation. Note the precise bilateral resection with the intact urethral floor on cystoscopic view. After completing the first treatment pass, I performed an additional pass, making contour adjustments as needed to reflect the anatomical changes in the prostate observed from the initial resection. The water jet will again initiate at the proximal region of the prostate and advance through the gland according to the updated treatment plan. Throughout the procedure, the treatment plan is visualized in real time. You can observe speculated tissue, which serves as a visual indicator of effective treatment. This corresponds to the different zones of tissue interaction with the water jet: the collagen removal zone, collagen disruption zone, and collagen preservation zone, each reflecting the unique properties and precision of the therapy. With the second pass, you can clearly see how the water jet interacts with the prostatic tissue in real time. Take note of the soft tissue removal zones and how the hydrodynamic forces precisely sculpt the resection field. As the water jet nears the prostatic apex, we enter the ejaculatory safety zone, where again we have the butterfly cut, focusing the water jet laterally and sparing the midline. Prostate vasculature is heavily concentrated at the bladder neck, where few major arteries are present. Focal bladder neck cautery was developed to specifically address the blood supply at the bladder neck. The technique was designed to allow athermal water jet resection to apply precise and limited cautery, balancing safety, efficacy, and functional preservation. Successful focal bladder neck cautery begins with decisions made during the planning portion of aquablation therapy. The most critical planning decision that impacts bleeding after water jet resection is the placement of the 2 marker and sagittal. Conservative planning at the bladder neck and minimizing water jet resection in that area reduces the exposure of major blood vessels that cause bleeding. Use the resectoscope to resect and cauterize within the bladder neck for optimal hemostasis. Careful consideration of planning for the median lobe and the mid-prostate and at the apex reduce the need for the resectoscope and application of thermal energy in those regions. Proper treatment planning can help maximize tissue resection, reduce exposure to major blood vessels at the bladder neck, and ensure appropriate treatment depth based on transverse and sagittal treatment markers. Start focal bladder neck cautery by irrigating the bladder and fossa to clear the field of blood and clots. Continue leveraging ultrasound imaging during this step as a guide for positional location of various instruments. It is critical to follow a methodical approach when performing focal bladder neck cautery. It is recommended to select a starting position within the bladder neck, resect all remaining adenoma to determine a resection depth, then follow that depth circumferentially. Resect remaining fluffy tissue and cauterize visible bleeders. If median lobe tissue remains, resect and cauterize that tissue. Finally, a very key step: position the scope at the apex, turn off irrigation, and inspect for active bleeders under normal blood pressure. Once hemostasis is achieved using focal bladder neck cautery, the resectoscope may be needed to resect median lobe, anterior, or apical tissue. Visually inspect the fossa by positioning the scope at the apex and confirming the channel is clear of obstruction. Once aquablation therapy is completed, place the balloon catheter and fill it to provide tamponade. Ultrasound may be helpful guidance for successful placement. Begin CBI and check effluent fluid in the catheter with a goal to stay within grade 1, 2, and 3. Now I've inserted my resectoscope, I've irrigated the bladder, and I'm going to start at the median lobe. And this is 2 times speed. And you can see all this avascular tissue, and then some BPH tissue as well. But I'm going to look at the bladder. I'm going to cut down until I see circular fibers. And that signifies I'm at the bladder neck. And I'm going to stop. And I'm also looking at the ultrasound. You can see the median lobe in that area. As I open it up with the loop, that area disappears on ultrasound. That's a really good reference piece that you have when you're resecting and removing tissue. And again, I'm very careful. I want to get this entire median lobe out. Now I'm going to systematically work my way around for focal bladder neck cautery. I go about 2 to 3 centimeters back. I remove all the avascular tissue, and then I cauterize. A loop is optimal for focal bladder neck cautery just so that you can remove the tissue and see what lies beneath. And again, I'm trying not to go too deep here. I'm not going to undermine the bladder. You can use the ultrasound as a reference to ensure that doesn't happen. I often see a flap here when you have an intravesical median lobe. And this is at the base of where the water jet treatment ended. And I just smooth that out. And you're perfectly fine resecting some tissue just inside the bladder neck, just again to get down to areas that could be bleeding. If you have an incomplete resection, it may bleed more. So the key here is really to get all this tissue out. And here you go. I'm at 9 o'clock. I'm going to resect this tissue. This is all this avascular tissue. And then boom, there's a bleeder. And I'm going to cauterize that. And that's going to really help with hemostasis. And I'm going to continue to go around circumferentially again, about 2 to 3 centimeters back from the bladder neck, just removing all this avascular tissue, cutting down until I can find areas of bleeding. All right, I'm going to highlight additional use of the resectoscope. You can see the anterior channel here. It appears to be hanging down, and this is outside the water jet resection. And an ultrasound, I'm looking at it, and then visually I'm looking at it with the cystoscope. I'm going to take this all the way back to the apex and really open this area up to maximize my channel. During this inspection, I also visualized the ureteral orifices and other key anatomical landmarks, including the verumontanum and bladder neck, to ensure anatomical preservation and procedural completeness. And remember, he had a large intravesical median lobe, and the bladder is totally fine. You can completely plan to take that out and rely on the precision of the robot. And check out the channel. Look at this in transverse. This massive channel that encompasses most of his transition zone. I'm going to scroll back, and you can see this channel continues all the way through the apex, but the posterior aspect of the apex is preserved. So the veru and the underlying ejaculatory ducts are saved. On ultrasound, I evaluate the prostatic channel in both transverse and sagittal planes to confirm a clear and symmetric pathway. We remove some anterior tissue, and that's wide open. All the avascular tissue posteriorly will slough off over time. And check out that flow. Look at that. Wide open. We're going to put in a catheter. This is a 22 French 3-way catheter, and you can watch it go in. I'm going to put in 40 cc's into the balloon, pull it back, and there you go. I'm going to irrigate this catheter a few times, start them on CBI, and we'll get them to PACU. A lot of men don't want to go through multiple procedures every few years. They want the best procedure up front, and I think aquablation affords that.